in English or in Spanish. I want to thank Fundación Querer and Pilar and Alfredo and all of you for having us here today and inviting us to speak again, and particularly to Sarah for all her hard work, although I don't think she's in here. We're going to build on what Dr. Hilnagel just said. So we're going to do a little bit more of a clinical aspect of drawing together genetics and epilepsy, and speaking about what people need to recognize early on that may not be just a problem with learning or communication, but actually has some underlying epilepsy components. So Dr. Wolf and I are co-directors of the Pediatric Epilepsy Program at Mount Sinai in New York City. So what we often look back and when we discuss our patients, we worry that things are missed and that children go undiagnosed for many years. And it happens in the best of schools and in the best of communities, as well as among our poorer population who doesn't have as much access to health care. So people will come in and say that their child is in school and they're not thinking well. The teachers are concerned that the child is spaced out or zoned out, or that the child learns something and then doesn't remember it the next day. They'll say that they're distracted, they're not following instructions well. The teachers will often say, I don't know what's going on and I can't tell how to get through to this child or how to teach them. And then in addition, the most worrisome thing is when a child has learned something and then regresses. It isn't speaking as well, isn't learning as well, isn't as smart as he or she was. It's not in my mouth?
Okay. No.
Okay. So some of the things that people mistake these problems for when they're actually an underlying epilepsy or seizure disorder is that the child is deaf. They're not paying attention because they can't hear what they're saying. I always think that about my husband and my two sons, is that they're either they've gone deaf or they're just not paying attention to me, and sometimes I think they're actually having a seizure. My husband would not appreciate me saying this. We worry that it's some sort of neurodegenerative disorder and they're going to get worse over time. And then children are often misdiagnosed as having anxiety or depression or selective mutism, which is a group of children who will speak at home but they won't speak at school. And the teachers get very concerned and think that there's something very wrong with them. We also worry that children are misdiagnosed with autism when they have an underlying epileptic abnormality on their EEG. They're misdiagnosed with learning disabilities or attention deficit disorder. There was recently, actually it's happened on more than one occasion, it was in my school district in the town that I live in. The child was 8, I think, and the mother was a teacher, and she'd gone through a whole year at school, and the teachers kept saying she has attention deficit disorder, she's not paying attention. And she came in and the mother said, she keeps staring. I think there's something more than this, and the mother being a teacher. And she came in and of course we had her blow on a piece of paper, hyperventilated her, and she had an absence seizure while we were sitting there and stared and zoned out. And this child was completely having this workup at school for attention deficit disorder. So what we want to bring to the public is that it's important for the educators and the parents to look for clues. Children who suddenly will have a movement disorder, so jerking, twitching, tics. Oftentimes children come in and we think that they have tics. I assume you're translating that correctly, where they have, an eye blinking or a twitching, and will not realize that there's an underlying seizure disorder, or that you can have tics and seizures at the same time. Again, the regression, the loss of language that we've spoken about a few times today, children with sleep disturbances that get written off as nightmares or wakefulness or snoring, and children with memory issues and worsening school performance. So some of the things that look like seizures but are not seizures, and we're going to show you some videos in a few minutes. So self-stimulatory movements, the children with autism who come in and they have this, either wringing of their hands or they're jerking and they're all excited, or that they just get overloaded and they can't understand what's being said to them and they just shut down and do not work anymore. Tic disorder I talked about, parasomnias, things like sleepwalking, sleep talking, eating during the night, nightmares, and then snoring, obstructive sleep apnea. So anything that's affecting sleep, so children who are waking up in the middle of the night or having snoring, that can also affect learning, but it also can be misdiagnosed as just a nightmare when it's actually a seizure. And again, important for the public to understand that not all seizures are big generalized tonic-clonic seizures. There are things that can look like ADD. I talked about the absence. The Rolandic and occipital epilepsy are seizures that occur out of sleep. We've talked about a little bit. Also, vomiting can be a seizure. It can also be a brain tumor. It may be misdiagnosed as a nightmare or a stomach upset. Landau-Kleffner, that we've talked about a lot, can look like autism or a learning disability. And then there are people who have falls, often in Dravet syndrome, where people will just fall because they have a movement disorder, and do people realize that this is really preceded by a seizure? I remember being in Grand Central Station in New York City a few years ago, and there was a man walking aimlessly around the train station with 5 or 6 police officers following him. And he was clearly having a seizure, and it was a long, complex partial seizure. And I finally walked over to one of the police officers and said, you know, he's not drunk. He's having a seizure. And they immediately sprang into action and called an ambulance. But who knows how long that would have gone on. So now we're going to show you a bunch of different seizures. Most of them are patients. This first one is a girl who underwent epilepsy surgery at the age of 17, but she spent years having these episodes out of sleep that were completely misdiagnosed as nocturnal parasomnia. And you can imagine, this looks like something weird happening in sleep.
So these seizures, if you can hear me, come from the frontal lobe, and she kept being told that she was hysterical or having psychiatric disorders. And you can see they're pretty elaborate kind of seizures. And you know, remember, your frontal lobe is an area of inhibition, executive functioning, and seeing these kind of things can really be upsetting, and she knew she wasn't doing them voluntarily. So it's a good example of, you know, where the seizures start really affects where the functioning of the brain comes from. Here's another example of something that we thought was a seizure. And this is just a sleep disorder, but it certainly deserved to be looked at because it was so unusual and strange, and this child does have a learning disability. And this was happening every night with a kid with a learning disability, and we wanted to make sure this child wasn't having seizures, and we were able to rule it out. And then, of course, here's a good example of autistic self-stimulatory behavior, which also can look like a focal seizure or something that just comes out of the blue, and is important to make sure that we're not missing subtle seizures. So this is what typical self-stimulatory, non-seizure-like behavior can look like. But it can be very confusing, just as Patty described the person walking around the train station confused. A lot of these self-stimulatory behaviors can be very confusing as well. And watch this boy, he sort of walks around in circles. He looks a little spaced out right now. And then he starts walking around and doing strange movements. And it's very hard to tell what these kind of behaviors are. But after evaluation, it was very clear that these were not seizures and they were self-stimulatory behaviors. Here's the classic hand flapping movements that we see some of the children do. And again, important to differentiate what these movements are and are they related to seizures or not, which is sort of important. This is an example of a drop seizure that doesn't look like a seizure. And this is a child who just goes straight down and falls to the ground and has a very hard fall. And that was a seizure. That's called an atonic seizure, where they lose tone. The professor before, Dr. Antonio, showed a tonic seizure, a spasm, which is sort of in the same family. This is a seizure that comes out of sleep that was written off sort of as a nightmare, which ends up being a seizure. And you'll see his hands start moving. And he's an example of a benign focal seizure that comes out of sleep. It's hard to see his face. One side of his face is involved more than the other. He has sort of this lip smacking. He looks like he's in pain. And this is a very benign seizure disorder that actually they outgrow. But families have come in saying, They find the child wakes up after this, he's slurring his speech, he's not able to speak very well, and it actually takes him maybe an hour or 2 hours for his language to come back after this episode. They're very short, but yet they're an example of a benign focal seizure that can be with a very temporary speech impediment that can happen. And now this is a girl with a tic disorder where she used to have absence epilepsy when she was younger, and when she grew up, she started having these wincing of the face episodes and movements of the mouth, and these turned out to be just complex motor tics. As Patty said, some people can have epilepsy and simple motor or complex motor tics as well. This is a young lady who has myoclonic jerks, where you'll see her arms go up in a very sudden way. Oh, that did not start. Hold on one second. And there'll be sort of quick little jerks, and then there'll be a big jerk. And it can be just as subtle as that. Some people call them myoclonic jerks or spasms, but again, that can be confused with a tic, as you already imagine. You can imagine it and confusing it. And here's a child with cerebral palsy and started having some severe jerking episodes, and the school teacher couldn't figure out whether these were seizures or not, so we brought her in to evaluate this excessive jerking that she does, and it ends up that this was not seizures, and it was all related to cerebral palsy. So basically what we're hoping you as clinicians and educators is to work with the families to try to figure out what's suspicious or what's not suspicious, and let the testing help you to make the diagnosis, because maybe it can prevent these episodes from happening or figure out the right probable treatment. So for this child, a muscle relaxant was the key, and she started doing much better and the movements got better. So the important thing is that people may experience loss of language with seizures, as we mentioned. And again, this could be a temporary loss of language, such as that seizure that I showed you that was focal that happened in sleep. But if the language loss persists, then we worry about epileptic encephalopathy. And Dr. Antonio had mentioned about this, and this is an epilepsy that affects the mental status of the patient. That's what that whole fancy term is. And there are many different disorders, as he described, that cause an epileptic encephalopathy. So it's important for us to differentiate what caused it and what caused the language loss to see if we could try to help the child.
All right, so the International League on Epilepsy classified epileptic encephalopathies, and we just went through some of this, so part of it's repetitive, but we've decided that it's better that we repeat everything a million times so that you'll really remember it. So epileptic encephalopathies occur when the epileptic activity itself, so the abnormalities on the EEG, contribute to the cognitive and behavioral problems above and beyond what might be expected just from epilepsy. So if they have epilepsy and they have seizures, but the EEG is normal in between the events, that's epilepsy. The epileptic encephalopathy is when there are so many abnormalities that it's affecting their cognition, it's making it worse over time, and that it's affecting behavior.
This is an example of the EEG. You've already seen this, and these are the spikes. We in America say anything that looks like it hurts to sit on is a spike. The way we describe this is each spike is equal to, imagine a man in the forest with a box of matches. Every time the man lights a match, that's equal to one spike. Now, most of the time he drops the match to the ground, nothing happens. But every once in a while he lights off many, many matches and throws it to the ground. It starts a fire, the fire spreads, and that's your seizure. So medicine waters down the ground to keep it nice and moist, so hopefully you won't have many fires. But your question is, why is there a man with a box of matches? And that's really our job, is to look at the MRI and see if there's something abnormal that's causing the man with the box of matches. And we saw some MRIs with polymicrogyri or strokes or scars. Sometimes we don't see the reason why there is a man with a box of matches, but the genetic testing shows you something abnormal, and that explains why there's a man with a box of matches. So really, all the testing we're doing is trying to figure out why there is this spike or why there is this man with the box of matches. But here's the thing. Research is telling us that this area, these matches, these spikes, are what's causing the problem with developing the language. And there's been a lot of research looking at how much spikes happen in a certain amount of time, or where the spikes are located. If they're over the language center in the perisylvian region, then it will affect language. If it's over the occipital area, it will affect visual performance tasks. But here we're really talking about language. So we know that if the spike location is over the language area, then we feel that that's going to impact the child's developing of language. So we know that spikes interfere with just the area of the brain that's affecting, but it also might affect the whole network of the brain. So really, we're really talking about what's the effect of spiking on the language. And Dr. Wolfram yesterday showed us a lot of amazing functionality or abnormalities looking at DTI, which looks at functional tracts of the brain. And really, we're looking at how the spikes interfere and don't allow the language areas that he discussed with the arcuate fasciculus and the inferior frontal orbital fasciculus, allowing those areas to work properly so you can get language production, where you can get somatic language, and that's why these children are having such issues developing language. So spikes are bad, and spikes in these areas affecting these developmental areas in language are bad for the brain. So we already know, we discussed some of the benign losses of language, where that child who woke up in the middle of the night, had a small seizure, had aphasia for an hour or so, and then it resolved. But there are cases that are more severe.
So let me just go back to that one last slide. So most of these childhood focal epilepsy, so that's benign childhood epilepsy with centrotemporal spikes, or Rolandic epilepsy, and Panetopolis, which is occipital spikes. That's the one where they vomit and it's really a seizure. The more recent research has shown that even though we call them the benign variants, they actually are associated with some comorbidities, including learning disabilities, particularly reading disabilities, and migraines, and then some behavioral issues. So even though we think that they're very benign, we still have to look at all the comorbidities of epilepsy in general. The thing with these, at this end of the spectrum, which is seizures that have a loss of language or an interruption of language, is that once the EEG normalizes, once you stop the seizures, the EEG goes back to normal, then the child is left with no long-term cognitive issues. But as we said in the previous studies, the more severe epileptic encephalopathies, there's a continuum, everything from Landau-Kleffner to CSWS to ESES, and they have transient or permanent speech and language impairment. They're more severe, they're less frequent, these are not as easily identified. And the other thing with these is that they may not seize as often. So those benign Rolandic and Panetopolis syndromes, they have clinical seizures. With the epileptic encephalopathies, the clinical seizures are less frequent. But what you look for is that they have, at the onset of drowsiness, when you're falling asleep is when the spikes increase in activity. And they persist all through sleep. So you're not laying down memory, you're not keeping in your brain the stuff that you learned during the day. So it's almost like you learn the stuff during the day, you go to sleep, you forget everything, you start all over again the next day. They can vary throughout the recording, they can get better and worse over time. So we always say it's important to do a 24 or 48-hour EEG and not rely on a routine EEG. They can change according to the developmental stage of the child. They can be spiking on one side, or it can be generalized, and then they can be affected by treatment. The whole point of treating them with medication is to slow down the spiking. If the spikes happen while they're awake, then the parents will most likely see a clinical seizure, and that'll be the clue to get the whole workup for epilepsy done.
So if this all sounds like you've heard this before, you did just hear
Yes.
this all before. Dr. Antonio Gil-Najal mentioned all this, but the point is that we want families to get their children tested routinely, to look in sleep, to look for these spikes, to see if that's what's causing the problem. Especially if the children regress or lose ability while you're teaching them, and suddenly they're learning and suddenly they're not learning? What's going on in sleep? And I know it's hard to get testing, but it's important for the families to ask, so we could try to ask for this. So this is, again, as Patty was saying, this is a spectrum. You can have a little bit of spiking at night, or you can have a lot of spiking at night. And this example, ESES or CSWS or Landau-Kleffner, are all sort of in this line. And these children, a lot of them have seizures, but the whole point is really that regression is there, and we got to watch for regression. So just to sum up, Landau-Kleffner, which we talked about before, is again not autism. This is something that we've had mistaken a lot in America. These children have an aphasia. They had language. They lost language. And then they have other symptoms of behavioral issues that happen because they're so frustrated that they lose the language. Anything else you could think of?
No, we're going to go on to why it's different. So it's the spiking of the brain that's the problem. We went through this already. So
we do want to make one comment.
Yep.
So unlike physical injury, so if a baby has a stroke, a lot of times where that area where the stroke is, that whatever functionality was there moves to another area and the baby adapts. That's called brain plasticity. But what's interesting about abnormal electrical activity in an area, it doesn't seem to allow that area to move into another area. It seems to have an inhibition to allow that plasticity. And we don't really understand that, because if you cut out an area, a baby's brain will move it. But if it's just spiking and having electrical activity, it doesn't move as well. So there is a difference between plasticity caused by a stroke versus an epileptic activity. Right? And this is just to make the comment, and Dr. Antonio had shown this slide before, is that when you sleep, you recharge your brain. And when you sleep, you lay memory. And if your brain's spiking away, it's using a lot of energy, and it doesn't allow the nighttime for the brain to heal, relax, and to lay memory. And that's why it's so important to do the EEG in sleep. We want to show you a video of a child who had language and lost language.
Who's that?
Big Mouse.
Minnie Mouse. And what's that? It's a phone.
Five.
So here she is, 17 months. She can name, she points, and this is a good example of a Landau-Kleffner child.
No.
And she's never had a clinical seizure. Now she's 2 years and 6 months. So it's clearly not the same child. She's got limited language there. She's not really following directions. Sort of spaces out a little bit. And this was a child who really had language regression. Now this is her 6 years old. And still minimal language development with extensive therapy. Her motor skills are affected. And you saw how good this child was at pointing at items and looking at the toy before. And she's really lost a lot of her abilities. Now, this next child has a genetic mutation, had spikes and waves over the opercular region of the brain, so it was over the language center. And there was a mutation. This child had a GRIN2A mutation, and we saw that in the last two talks, is one of the genetic mutations that is associated with Landau-Kleffner syndrome. And here you can see the child before treatment with high-dose steroids.
L'oiseau. La. Bravo. Très bien. Le crayon.
So of course it's in French, it's not in Spanish. I tried to find a Spanish patient, sorry.
Et la voiture. Prends un peu le marqueur vert.
So really no spontaneous speech.
Prends un peu le marqueur. Je donne d'abord la couleur. Le
He can
marqueur
do
jaune.
he can follow
Et le
commands.
jaune. Là, très bien. Essaye un peu de dire la couleur de celui-ci.
And this child had already regressed in the past,
Vert.
but I want to show you what he looks like before treatment and then after he got high dose steroids, how his language comes
Alors,
back.
Essaye de dire un peu papa. Papa. Maman. C'est maman.
Tu sais le faire? Non? Ah, ok. Elle sort pas du tout ta langue? C'est comme ça.
So real expressive aphasia.
Comme ça. Fais un petit peu bouger la langue. D'accord. Tu as bien dit maman, alors tu vas me dire ça c'est une main. Ok, super.
Can't really stick out his tongue too well.
On va faire encore un autre. Celui-là, tu veux
So it's a
essayer?
real oral motor apraxia.
Alors, si tu connais, comment est-ce qu'elle fait? Comment est-ce qu'elle fait la vache? Fais un petit peu. Elle fait. Essaye. Et après, il y a tout. Après, c'est presque tout. Alors, comme ça, on essaye. Ça va? Alors, on va essayer de monter la langue vers son nez, en haut.
It's gonna switch.
Super, en bas.
I hope it is. Second part.
C'est vers là.
Now this is him after treatment. If I recorded it properly.
It was there.
Oh,
It was there. You could see his face.
I did something wrong.
There. And you can tell he's been treated with steroids because look at how fat his face is. That goes away after the steroid treatment. It's right here and there.
Et après, il y a tout. Après, c'est presque tout. Alors, comme ça, on essaye. Ça va?
So he could stick his tongue out now.
Il a une pointe. Alors, on va essayer de monter la langue vers ton nez, en haut. Super, et en bas.
You can actually hear him say, "I don't like the wires."
Il s'est touché, lui? D'accord, essaye vers le bas. Tu as vrai? Non, ça, c'est pas chouette.
So there really is a significant improvement in his language and following directions, which is impressive. So the point is with Landau-Kleffner, it can be reversible, partially reversible, usually before the onset of 6 years of age. It is an acquired verbal auditory agnosia with cognitive and behavioral issues. Not all the patients will have clinical seizures. Some patients will not have any clinical seizures, they'll just regress. And seizures, if they do happen, will be in sleep a lot of times. And some of them will just spontaneously remit, the seizures will stop, but the damage will be done. The language disorder will be there and be very difficult to treat afterwards. Go for it.
All right, so this just goes back to typical language development. So at 7 months old, the children can recognize most of the sound distinctions of the world's languages. By 11 months old, they recognize only the language of their environment, so whatever country they're living in. And then we actually, Wolfram had talked about this yesterday, about the connectivity between the primary and secondary association areas and then planning and judgment. This is again back to LKS, the onset can be abrupt or gradual. Sometimes the language regression begins before the disorder starts, and it can also happen in children who have a pre-existing speech delay. But again, it starts, we're just talking about the child no longer recognizes the father knocking on the door when he comes home. So it starts that they don't understand what's being said to them. The hearing tests are done, they're normal. They don't understand the sound, so they can't interpret what's being said to them. And then they have trouble understanding complex and longer instructions. So when you say, go up in your bedroom, get your shirt, put it on, come back down, put your shoes on, they can't do that. And maybe still, if you say to them, get your shoes, they're able to do that. And then it can progress to the complete inability to understand any spoken language. And back to the father knocking on the door and not recognizing that's daddy coming home for dinner. They cannot understand a dog barking, a siren on an ambulance, traffic noises, telephone. You can imagine how severe and dangerous that is to a child. So the clues to start noticing this is that the child starts using shorter sentences. And again, this goes back to, is it something that's misdiagnosed? Is that an anxiety issue at school? Is it selective mutism? Is there something else going on that the child's worried and not speaking as much? Or is there really an epileptic encephalopathy happening in the background? They have trouble finding words. They pause when they're speaking and they use the wrong words. So one of the examples was saying galat instead of giraffe, or gelat instead of giraffe, or stick instead of pencil, almost like an older person who has word finding difficulties and can't think of what they want to say. And then changes in intonation and speech quality. So slurred speech, jerky speech, I'm losing my own speech. So children with autism, you know how they'll have that sort of odd intonation at times, so it'll be similar to that. And they may completely use speech and start using gestures to make their needs known. And then the fine motor issues. So the fine motor issues don't occur because they're having trouble saying what they need to say. They start drooling, they can't use utensils to eat, they're clumsy, they have tremors. They may not have any of that movement stuff, but they may also, and the course is variable. And there's a big fluctuation in the behavior and the abilities. So that's why it's important in school, after they've been diagnosed, is for the teachers and the educators to be aware that there's a big fluctuation day to day, but also to notice if there's a downward trend, because that's a signal to go back and do more testing and see what's going on. So the way that you differentiate between autism and Landau-Kleffner or any of the epileptic encephalopathies is that the language regression is more global and associated with the emergence of autism, and that's diagnosed at a younger age, as Dr. Flauberger was talking about, so 2 to 3 years old, and it's a little bit older in the epileptic encephalopathies. So in autism, about a third of the parents reported that the language regression occurs between 18 and 24 months of age, and that 95% of it happens before the age of 3. In LKS, only 13% of the children regress before the age of 3. In autism, the regression is global, so they have behavioral and language problems at the same time. The self-stimulatory behavior appears, the lack of eye contact. But in Landau-Kleffner, the behavior comes as a result of the child's frustration at being unable to communicate. And they're still trying to be social and interact with other people, but they're frustrated that no one is responding to them.
And you saw that in the video. He was able to identify the green pen. He was pointing out to things in the book. He was doing everything but creating language.
And again, this is the same, the seizures. So in autism, there's 2 peaks of epilepsy in autism. So there's a large percentage of people who have autism also have seizures. So there's a peak in early childhood, like 2 to 4 years old. And then there's another peak that we see with autistic patients that's in adolescence, often even in late adolescence, 18 to 19, and they all of a sudden will have their first seizure. And these are even in people that we've done a workup and we've had EEGs that were normal at the time of the first diagnosis.
But the point we want to make is that there are patients who have autism and have epilepsy. And even if you control their epilepsy, their autism doesn't change. And then there are people who have epileptic encephalopathy where they look autistic, they're not having language, you treat them, they get better. So there are 2 worlds. So we can't promise people, just because we have epileptic discharges and you're autistic, that you'll necessarily get better. And we tell families that early on, which can be very frustrating.
So again, the recognition is the most important. So that's why, we say in the United States, it takes a village. So people need to speak up if they're seeing something going on and to, pursue a further investigation. So again, the workup is, as we've all said, the overnight EEG and MRI and the genetic testing. And we're doing the same things in the States. We're getting genetic testing right away when people are first diagnosed, but that's a hard thing to sell. So we even have people in our own epilepsy program, and we have 2 big NIH studies going, National Institutes of Health study going on, one with epilepsy and autism, and one with the impact of genetic testing and follow-up on the outcomes of the underserved population in New York City. And we still have clinicians who will say, oh, you're testing everybody. Why are you doing all this genetic testing? And yet, we're not going to be able to tell what the causes are and what the treatments are unless we get a larger number of people who've been tested. So again, the causes can be structural abnormalities, genetic abnormalities, and then autoimmune.
So Antonio had shown you a MRI of something with polymicrogyri. This is another example just showing you this abnormal area of cortex on this area of the brain. It's flipped, but this is the left side, and obviously affects this child's language development happening here. And looking, we already saw PET scans. PET scans look at the metabolism of the brain, how your brain breaks down sugar. And basically it could show you that there's not good functioning in a certain area of the brain, and in some of these cases we could see that the sugar is not breaking down properly in the left temporal lobe where language is produced, and this is a bad PET scan that's supposed to show you that. So this test could be very useful in pointing it out. As Dr. Antonio had mentioned before, the genetics is really going to change how we look at children. We used to think when patients had epilepsy that we knew some of the reasons they had epilepsy, whether it was from birth damage, something they were born with, a congenital lesion, infection, neoplasm, and basically 3/4 of why someone had a seizure was idiopathic, which in America means we're idiots, we didn't know why it happened. But now we know that 3/4 of idiopathic has to do with genetics. And if we don't investigate the genetics, then we're not going to get to the bottom of it. And right now we're at a point where about 20 different genetic disorders actually will tell you how to treat the patient. We have about 150 genetic disorders that we know cause epilepsy. We have about 150 to 170, depending on the day, that cause autism. But we know about 20 that clearly decide what treatment we should do or not do. And Antonio discussed the SCN1A, the Dravet, which we know don't give them a sodium channel drug. You're going to make them worse. So it's important that we get these diagnoses early, that we convince our governments and our insurance companies in America that they should pay for this testing early because it's getting cheaper and it's going to change our treatment as these children go on and let them hopefully have a better quality of life. We already got a very good lecture about testing, and chromosomal microarray is sort of looking at genetics at about 10,000 feet. It's not that useful. It only gives you about 5% of the diagnosis, but gene panels, which are very cost effective and can look at about anywhere from 20 to about 155 genes, can have a diagnostic yield up to about 50%. And this is a very low cost testing, a few €1,000 with good testing, but could really change the way we treat a child. And then if that testing doesn't show anything, the more expensive is to look at whole exome, which is 22,000 genes or 23,000 genes. And exome, remember, are the pieces of DNA that make protein. That we know that make specific proteins that do something to your body to make it function properly. And if you're missing a gene that's not going to do its job, then something's not going to happen. So it's imperative that when we walk out of here, we really mention to the people that have the power to allow us to do genetic testing here in Spain that this is an important treatment. It's not research, it's a potential treatment to change the way we treat children. And you already saw this slide, and this is 5 different known genes that are very much associated with these epileptic encephalopathies where you lose language. So again, genetics is not very well understood. We're in the process of learning all this. We know that genetics influence lots of different epilepsies, and also The genetics is only one part of it, as we had a really good genetics lecture, that there's an autoimmune process possibly going on. There's, and maybe we all carry a genetic risk factor, and that genetic risk factor from whatever mutation we might have with some environmental process or some inflammatory process might trigger that gene to then express itself and for the child to then develop epilepsy. So it's not as simple as you get the gene. You might need 2 hits to make that gene become active. Maybe environmental, maybe an infection, maybe, I don't know, something. Politics, I don't know. Something causes that gene to become active. So we really just have to learn this. We learned in the last lecture that there are many different medications, and we're not going to go into them, that can help with epilepsy, so we need to investigate them. And really the conversation you should have with the family is, if that first medicine didn't work, go back, talk to your provider, and come up with another drug to try. You need to keep trying different medications, because each medication, as Antonio showed you, works in a different mechanism of action. And we don't know exactly which mechanism of action for each child or each genetic disorder is required. So you need to keep trying different families of medications until you find something that makes a difference. And that's sort of the point of about the medication conversation. It's very easy for a family to get frustrated and to give up, saying, I tried 2 medicines, it's not working, the side effects are too bad, but you need to keep trying and looking at different combinations, because that will be the best way to help the child better control the spikes, which will then hopefully better decrease the irritation to the area of the brain and allow that brain to develop. You want to?
So, and the other, just to add to that, is that we're sitting here in a consortium that's the best and the brightest from all the major cities, but what we have to remember always, and what I always say in the States, is that we need to get the word out to the rest of the country, to the people that don't have access, that the people who don't know that the treatments exist, who don't know what the testing is. And I mean, everyone thinks that the United States has everything and we're so ahead of the game, and we're not. We have large pockets of our population that don't have access to medicine, that don't have access to testing, that don't have access to neurology. So, you know, I think it's just, we all have to go forward and sort of teach the other people as well.
Just to talk, and because we were, one of the sponsors of the program is Foundation Columbus, which we appreciate their contribution, and just the genetics really are the future. And possibly having genetic treatments for these disorders where you can actually go and replace the genes is really fascinating. And I really feel that over the next 10 years we're going to be seeing a whole robust new generation of treatments that are going to be doing to genetics. So the next few years our lectures are going to change.
Do you want to talk about gene therapy? Or?
No.
Okay. All right, so and the most important thing, so as we're doing the medicines and trying to calm down the spiking, the most important thing to remember is that we still, language therapy, so for them to communicate and learn, we really need to have intensive speech language therapy. So the child has to feel at ease, they have to not be worried or anxious, and it has to be integrated into the whole classroom environment. So the therapists need to work with the medical team and the parents. And what happens, at least in the United States, is that it's often fragmented. What you have is an amazing thing. I have a child with a speech delay who does not have Landau-Kleffner. Now he's a grown man. But I remember how difficult it was to have the whole team get together. It wasn't part of his program, and we'd have to beg to have everybody meet together to talk about what was the biggest help to him. So the key elements of the school program are a comprehensive approach, good communication between the parents and the school. We struggle with that too, because we have a lot of working parents who can't get into the school, who are not available to come in for teacher conferences. We have parents who can't come in with their children even to their appointments with us. We'll have grandparents bring them. The new thing at our hospital system is that they can't check in the child unless the parent is there to sign a release. So, you know, grandparents come all the time, aunts and uncles come, babysitters come, and then we get the parent on the phone. But the newest thing now is that you can't do that without having a parent present. So there are all these barriers that are put up that we need to keep pushing through. So they need to have a monitoring of the ability and for the teachers to call and say, there's something wrong, there's something going on, take another look at him. They have to be able to get through on the phone, so somebody in our office needs to be able to answer the phone, which is another issue. We need to encourage peers and socialization and to educate the peers that the child is not walking away from them because they don't want to play with them, it's because they're frustrated. The educational choices, this is in the States. You can have a regular school setting, you can have a special ed school, you can have a school with just language support, schools for those with hearing impairment, and then beyond high school, we don't have a great vocational program in the States. We tend to put people into intensive language programs with simple language, alternative communication, parental involvement, and then the planned team meetings that I talked about. The other thing is that sign language. So sometimes people feel like they don't want to teach children sign language or they don't want to use them to use a PEX, which is a board with pictures, because they think they will not learn to speak. But the feeling and the literature is that using sign language facilitates communications. You want them to communicate by any means, whatever it takes. It will not stop them from developing spoken language. And then we have something called an individual educational program. So we have federally mandated accommodations, that's called the 504 plan, and then we have an individual education program. And we often will write letters saying specifically what the child needs, which is extra time for tests, word processing instead of writing. You know, some kids just really, my son was one of those, and they kept insisting that he learn to write, and I kept saying, guys, he's not gonna write, but he can type. So the sooner that they start an alternative means so the child's not frustrated, the better. Scribes, which are people that write the answers to tests for them, and modifying language using bigger prints and extra time. And again, I talked about this. The performance can vary even without a day. They need to report regression, speech therapy, and when to take away some of the supports and allow the child to progress on their own. I think in the United States, once a child gets into a special ed class, they tend to stay there depending on their socioeconomic status and the ability of the parents to integrate with the school. So oftentimes those parents who are not as well able to advocate, who maybe don't speak English as well, maybe are poorer, that child stays in special ed forever, even though the child may have been able to progress out of it. Mm-hmm.
So basically, we just want to summarize that epileptic encephalopathies, even when the spiking disappears, there can be neurocognitive and behavioral problems. And outcome sort of depends on the severity of the initial regression, and that early recognition is really the key, and that therapy is really the key, and also education. And again, that's a plug for a school like Cecilia and Pepe's school, that these kind of schools are really important to have available to these children.
Absolutely. So the more that we can do to help take care of this part of the population, the better the outcomes will be. The more genetic testing that we can do and the more research we do, the better.
Thank you very much.
Thank you.